Hi, everyone. Welcome. We're just going to give folks another minute or so to get logged in, and then we'll get started. Okay, we're at just a couple of minutes after the hour. I want to welcome everyone. Thank you for joining us. Very happy to be here and very excited to be hosting Dr. Melissa Wachterman. Dr. Wachterman is a practicing palliative care physician at the VA Boston Healthcare System. She is a member of the Veterans Experience Center analytics team, and over the past 9 years has led a number of projects aimed at improving the quality of hospice and palliative care delivered to veterans with serious illness. We're thrilled to be hosting her, and I want to get started as quickly as possible. Just a couple of quick housekeeping things. Yes, this webinar is being recorded and the slides will be shared. They will be posted on the We Honor Veterans resource page within the next week or so. If you have any questions during the presentation, please feel free to drop them in the chat or enter them in the Q&A. We will be leaving some time at the end for a Q&A. So without further ado, I would like to hand it over to Dr. Wachterman.
Great. Well, thank you very much, Catherine, for that very kind introduction. I had prepared a couple of things I was going to say, but it was everything that you said. So the thing I'll just add then is what an honor and a pleasure it has been working with the Veterans Experience Center with Scott Shreve sort of at the helm as the head of the National Hospice and Palliative Care Program out of the Geriatrics and Extended Care, and then also working with Ryan Weller and of course, Catherine. So it's been a real honor. So the title of my talk is Quality of Hospice Care for Veterans in VA Nursing Homes and VA Paid Community Nursing Homes. Next slide. So here we just have the disclaimer. So, materials based upon work supported by the VA. The views expressed are those of the authors and my co-conspirators, and do not necessarily reflect the position or policy of the VA or the US government. So before I start, it's always helpful to just get a little bit of a sense of who's in the audience. And so Catherine has very kindly prepared a quick poll. So if people just want to take 1 second first. So what's your position? Which category or other? And whether you're a VA employee or a non-VA employee. Wow, social workers represent. And nurses, great. Love it. Couple doctors, spiritual care, communications, CNA, volunteer coordinator, manager, CEO, executive director. Great. And then scrolling down. Oops, Catherine, that's probably on me. Let's see, scrolling down. All right, so 85% from the VA and 15% for non-VA. So I promise for the 15% non-VA, I will explain all acronyms, and the VA is notorious for lots of acronyms. So no, that's very helpful. So I really, I appreciate that. So let's go ahead and get started so we can go to the first slide. So the VA commits to ensuring access to high quality hospice, and research comparing end-of-life care for patients with and without hospice has shown that hospice care is associated with better pain management, better bereaved caregiver mental health outcomes, and better patient and family reported care experience. And part of the VA's commitment to honoring veterans' choice is a commitment to honor veterans' preferences for the setting in which they want to receive hospice, be it at home or in a facility, provided that it's clinically appropriate. And this facility-based hospice is really an important option when the end-of-life care needs exceed the capacity of the home setting. Next slide. So the VA offers facility-based hospice in two ways. So the first is through VA community living centers. So VA community living center based hospice. And VA community living centers, basically VA nursing homes. And within the CLCs, there's kind of two settings of hospice care. One is on the general CLC unit, and then the other is in hospice and palliative care units, or specialized parts of a CLC floor dedicated to hospice and palliative care. And then the other setting in which the VA offers facility-based hospice is community nursing home-based hospice. And here the setup is for veterans for whom the VA places in CNHs for the purpose of hospice care. So not veterans who are already residing in a CNH, but for those who the VA places for the purposes of hospice care, the VA pays their nursing home, room and board, and offers to pay for hospice services, which are delivered by a community hospice agency. So this VA hospice benefit lies in contrast to Medicare's hospice benefit, which will pay for community nursing home agency services, community hospice agency services in the nursing home setting under the routine care hospice benefit, but will not cover the cost of the nursing home room and board, except in rare and time-limited circumstances. So a really unique benefit that the VA offers veterans. So next slide. So historically, the vast majority of this facility-based hospice care was provided in CLCs, but the demand for CNH-based hospice care is increasing for a couple of reasons. So one, veteran need is starting to exceed CLC supply. So with the rapidly aging demographics of Vietnam-era veterans nearing the end of life, there's an increasing need, and this will only continue over the next couple decades. And then increasingly, CLC resources are increasingly focused on post-acute care. So while we say CLC equals VA nursing home, it's really sort of nursing facility care. So some post-acute care, knee replacement, sometimes those patients, and then also sort of long-term care. So again, reasons for the demand for CNH-based hospice care increasing. We've talked about veteran need exceeding CLC supply. And then second, more veterans may elect CNH-based hospice. For those in the room, very familiar for those that are VA employees, the Choice and Mission Act, but for those who are not, sort of increased access for veterans to receive community-based care. And thinking about this, this is a particularly beneficial option for veterans who don't live near a CLC. So if you live 2 hours from a CLC, the idea of having your end-of-life care be in a CLC, your family 2 hours away, it's going to be, it's a real resource that when time is short, the value of that time and being able to be close to family is all the more important. All right, next slide. So stepping back just from the VA, just taking a step back to say, the nursing home setting is a critical venue for death. More than 1/4 of all deaths among older adults in the United States occur in nursing homes. And more than 1/3 of nursing home residents receive hospice services. Next slide. So thinking about this and knowing that so much end-of-life care is happening in nursing homes, understanding the quality of nursing homes is really important. So in 2022, National Academies of Science, Engineering, and Medicine published a 600-page report on nursing home quality. And some serious concerns were raised about nursing home quality. The report deemed the delivery of nursing home care in the US as largely ineffective, inefficient, fragmented, and unsustainable. And the report specifically pointed to a severe lack of patient and family centered data about the quality of end of life care in nursing homes. Next slide. And the report specifically highlighted that the VA does collect such data in VA nursing homes. Next slide. So we'll talk about that data, that data. But first, I want to take a step back and just introduce you to the Veterans Experience Center, which, as we'll see, is the group that puts out the bereaved family survey. So we'll talk more about that. But just to take a step back, so the Veterans Experience Center is a quality improvement program funded by the National Hospice and Palliative Care Program Office within the Department of Veterans Affairs in the Geriatrics and Extended Care Program. And there's two key goals for the Veteran Experience Center. The first is to identify unwanted sources of variation in the quality of end-of-life care provided to veterans and to improve the care of seriously ill veterans across the VA healthcare system. And then two, to define and disseminate processes of care, best practices that contribute to improved outcomes in a number of different domains, which, as we'll see in the next slide, are measured by the Bereaved Family Survey. The next slide. So the Bereaved Family Survey provides data about families' perceptions of the care that their loved one, their veteran, received during the last month of life. And so since 2010, the BFS has been administered to families of all veterans who died in a VA medical center nationwide. And so we're talking about acute care, on the floor in the hospital, intensive care units, and then bolding community living centers, and then also inpatient hospice and palliative care units, which are often housed in the CLCs, but not exclusively. Next slide. And in fiscal year 2020, it was expanded to include families of veterans who received hospice services in VA contracted nursing homes. Next slide. So the little pictorial image here of the Bereaved Family Survey. So it's administered phone, mail, online, all options, 4 to 6 weeks after the veteran dies to the next of kin. It's has established validity and reliability, and it's available in both English and Spanish. And the response rate is about 40 to 50%. So 40 to 50% of the next of kin who get contacted with the Bereaved Family Survey respond, which is actually, having done survey research sort of inside and outside of the VA, it's quite good. The VA is doing a really good job getting a high response rate. All right, next slide. Okay, so the Bereaved Family Survey, what are we measuring? So the Bereaved Family Survey includes 20 items or 20 questions. 2 of them are open-ended questions, and then the additional ones are all survey-based questions. So the first is the overall rating of veterans' care in the last 30 days of life. So the bereaved family member is asked to rate the overall quality of care in the last 30 days of life. And this is actually a National Quality Forum endorsed performance measure, which is a big deal. There's a high bar to have something be listed as a National Quality Forum endorsed performance measure. And then in addition to this overall rating, there are a number of additional questions, and we often just kind of group them into 3 groups or 3 factors. So communication and care. When we move along, we'll see the 5 items: emotional, spiritual support, 3 questions there, and then VA death benefits, and there's 2 questions there. And then lastly, the last group are some single items related to symptom management: pain, post-traumatic stress, care coordination. Next slide. So we started from the premise that little is known about the quality of CNH-based hospice. So our objective was to compare the quality of end-of-life care provided to veterans in CNH versus CLC-based hospice care. And our data source was, as we've talked about, the Bereaved Family Survey, and it was for veterans who died in CNH versus CLC-based hospice care between October 2021 through March 2022. So really current data. Next slide. So our primary outcome was this overall rating of the veteran's care in the last 30 days of life, and it got broken into two groups. So those that rated it on a 0 to 10 scale, a 9 or a 10, sort of excellent, versus all other responses, because we're really going, our veterans deserve excellent care. And then there's a number of secondary outcomes, as we saw earlier on in these factors of communication care, emotional, spiritual support, VA death benefits, and then some symptom management items. All right, next slide. Okay, so here we look at some characteristics of the veterans in community nursing homes compared to the CLCs. So we see that there were in total 1,238 veterans during this time period. Still, the majority were in CLCs, so just over 1,000 were in CLCs and 226 were in community nursing homes. And so comparing the average age, those in the community nursing homes were a little bit older, 84 compared to 80 in the CLCs. Those in the community nursing homes, a higher proportion were non-Latinx white, so 84% compared to 77% in CLC hospice. And in contrast, sort of balancing that, in this community nursing home hospice, about 3% were non-Latinx Black versus 13% in the CLCs. The next of kin relationship, so the person answering the survey in the CNHs, about half were the spouse or partner, whereas in the CLCs, about a third were spouse or partner, the remainder of which were other relationships, child, sibling. And then the length of hospice stays. So hospice stays were longer in the community nursing home than they were in the CLC. All right, next slide. All right. Okay. So this is kind of like the central slide. Like this is in the paper that we wrote. This is like the key figure. And I'm going to walk you, we're going to spend a fair amount of time on it. And I'm going to walk you through it because I think looking at it at first, it can be kind of overwhelming. But spoiler alert, right here in the title of the slide is the key message, which is that the quality of end-of-life care was substantially better in CLCs, VA nursing homes, compared to community nursing home hospice. All right, so looking here, we see the BFS questions. And so for the first one, that primary outcome of the overall rating of end-of-life care. So we're going to see the proportion or the percentage who rated it a 9 or a 10, that top box rating. So we see that in the community nursing homes, 71% reported a 9 or a 10 compared to 85% in the CLCs. So this is a pretty sizable difference, about 14 percentage points different. All right, so now the right side of the slide, let's just walk through this because again, it can seem a little, oh, but there's some good stuff here. So we see the AOR, so odds ratio, and I'll tell you the adjusted odds ratio in a second, but odds ratio, essentially what we're saying here is that those in community living centers had 2.35 times the odds of giving this highest rating. There's a little sleight of hand, essentially not quite, we're 2.4 times as likely to rate it as a 9 or a 10, but that's the idea. And then pictorially, I think that it's helpful. It's called a forest plot. But what you see here is the dotted line. When you have an odds ratio of 1, there's no difference. And so then to the right of it, as you can see, that arrow, CLC better, and to the left, CLC better. And down, if you're on the left side of the dotted line, then the CNH is better. And so we see right away that all of the dots are to the right. So on all of these measures that we're going to go through, the CLC had better performance. All right, so let's go through it though, because I think it's important. So the first couple ones were in the care and communication. So the staff always took the time to listen. So in the CLCs, 82% of the time, they said always took the time to listen, compared to just over half within the CNHs. Staff always provided wanted medication and treatment, 87% in the CLCs, 70% in the CNH. Let me just say one broad statement about, we have the overall rating of end-of-life care, and we see about the 14 percentage point disparity there. When we look at all the individual items, you're going to see that the disparity was even larger when you ask about specifics. Staff was always kind, caring, and respectful, almost 90% in the CLCs compared to 71% in the CNHs. Always kept the family informed, 76% within the CLCs, whereas just over a half within the CNHs. Always provided enough spiritual support. So now we're on to that second group of emotional and spiritual support. So almost 80% within the CLCs compared to, about 61% in the CNHs. Staff always provided enough emotional support before death. So over 3/4 within the CLCs compared to just half in the CNHs. Always provided enough emotional support after death, 78% compared to 63%. Moving to symptom management. So patients' pain was always managed well by the staff, 81% in the CLCs compared to 65%. So a third of patients, their pain was not felt by their next of kin to be well managed. Always received help for trouble breathing, similar disparities. Always received help for stress related to combat and traumatic events. So 84% in the CLCs compared to just over half, 58% in the CNHs. Family received helpful information about VA, survival, burial, and memorial benefits. So this was one of the most profound. So 85% within the CLCs compared to less than half, 48% in the CNHs. And just moving over here again, looking how far out that dot is. So 6.6, those in CLCs, 6.6 times the odds of feeling that they received helpful information about survival benefits and memorial benefits. This next one's a little weird, the wording, but the family did not want more help with funeral arrangements. Like they got enough help with funeral arrangements. 3/4 of those in the CLC compared to only 60% in the CNHs. And then lastly, the family always knew who to contact with questions. Again, 3/4 in the CLC compared to just over half in the CNH. All right. One piece I'll say just from a methodology perspective, but it has an impact, which is that I said that these are adjusted percentages and adjusted odds ratios. And by this, I mean that we adjusted for the characteristics that we saw in the previous slide, age, race. And what that does is ensures that the differences that we see in the BFS ratings between the CNH and the CLC, that they're not explained by differences in the age distribution between the CNH and CLC. So that's makes us feel even more confident about our findings. Okay, next slide. All right, so you might be asking yourself, well, but you said earlier on that within the CLCs that some people got it on general wards, CLC nursing home wards, and then others had this care within these hospice and palliative care units. Like maybe it's that the hospice and palliative care units have really high ratings and that the CLC wards, like that's more like a community nursing home. And the punchline here is no. The quality of end-of-life care was high across CLC unit types. And so I won't belabor going through each of the items because they're the same as they were before. But, just to say that on our general CLC wards, 82% rated the overall quality 9 or 10, and 85% in the hospice and palliative care units. That's kind of the biggest difference, like a 3 percentage point difference. Looking down at the others in terms of receiving the treatment that they want, kind, caring, respectful, emotional support, pain well managed, very much on par. All right, next slide. Okay, so thinking about limitations. the study. So the first is that we didn't have clinical data on veterans who received CNH-based hospice, right? So within the VA, we have our whole electronic medical system, and we have so much information about all the different medical conditions that people have, all sorts of different clinical information. And we didn't have that degree of information for those in the CNH-based hospice. So thinking back again to this ability to adjust for or account for, well, it's not because of these differences. We were a little bit more limited. The second piece, and it was me that made the slide, I listed here under sort of that confounder relationship, like I just described. But the key part is, so we had a lack of information about structural characteristics of the CNHs and the hospice agencies, things like staffing levels. And just to say, these aren't things that we would want to like adjust out the impact of. These are really like probably part of the mechanism behind some of the differences that we're seeing, but it would be really helpful to have that sort of information so that we could compare. And then the second major limitation is that we have the limited ability to address the why and the how. And that's how you're really able to change things, is you have to understand. So we see these differences, we see these disparities, like why are there these disparities? What are the barriers? What are the facilitators to the delivery of high quality end of life care in CNH based hospice? And so this is really a call on the research side, sort of for qualitative research. I mentioned at the beginning when we were talking about the bereaved family survey that we have these 2 open-ended questions where veterans' families are able to answer the question of, what could have been better? And so a future direction that we have is to look at that data, and then even better, or not better, but in a good complement to that, Dr. Ann Cutney Lee, who's the director of the Veterans Experience Center, and I recently received some funding through the VA. And one of the goals of that funding, one of the pieces that we're doing with that research, is to do interviews, to go out to community nursing homes and hospice agencies and hear the stories from all different levels of, from the CNAs to the key administration, what are the barriers? And there's some CNHs that are doing this really well. And so learning from them, what the high performers, what can we learn from them that could be applied to other community nursing homes. Okay, next slide. So first, this slide just kind of summarizes, concludes what we found. So markedly higher quality of end-of-life care in CLC versus VA contracted CNH-based hospice care. So the percent of bereaved family members who reported the excellent overall care was 13 percentage points higher in CLCs compared to CNH's hospice. And then the quality gaps or of even greater magnitude for a range of specific end-of-life care domains, with some of the largest gaps being in PTSD management, emotional support, and guidance around VA survival and funeral benefits. And then another key conclusion was that the CLC quality advantage held regardless of whether hospice care was provided in CLC-based hospice units or in general CLC units. Next slide. All right. So what could be contributing to these disparities? So I think the first category is thinking about differences in the hospice care delivery. So, CLC-based hospice is provided in the country's only integrated healthcare system, and one that has made a very strong commitment to end-of-life care over the past 20 years, invested a lot of funding, and has, the greatest, brightest minds at the helm with Dr. Scott Shreve, and of course a host of others. And this contrasts with VA contracted CNH-based hospice care is provided by a combination of CNH staff and community-based hospice staff. And so quality is going to be a function not only of the quality of care that each provides, but also the quality of their coordination. So, when you have a veteran who's being cared, receiving CLC-based hospice, it's the, VA staff. There isn't this distinction of, well, now this is the hospice and this is the nursing home. There's really a lot of integration. Okay, next slide. So a couple other buckets that may be contributing to some of the disparities, or that, CNH and community hospices may not feel prepared for some of the unique end of life needs of veterans, using the example of PTSD. But, I think, consideration of the unique physical, emotional, and spiritual needs of veterans at the end of life, it's critical to providing high quality end of life care. So, veterans are more likely than civilians to experience chronic pain, to be diagnosed with mental health and substance use disorders. Some recent work by the Veterans Experience Center found that these conditions, including PTSD, are more pronounced at the end of life among Vietnam era veterans than among those who served in prior war eras. So this is going to be even more important, in the coming years and decade. And then the last piece here is that, the CNH and hospice agency staff, may not be familiar with these sort of complex challenges that veterans face near the end of life. So that's one point. And then the second bullet point, which is equally important, is that the VA may provide insufficient support to veterans in CNH-based hospice and their families. I sort of say that there's some low-hanging fruit, in the sense that there's really no reason why something like VA death benefits our bereaved family members, regardless of whether their loved one received care in a CLC versus a CNH, like, we should be able to be good at that in both. There's some that are going to be tougher, sort of the minute by minute care, bedside care. The VA isn't able to intervene necessarily in such a direct way on a minute to minute basis. But some of these other pieces of emotional support after death, these are things where I feel like there's really room for the VA to intervene. All right, next slide. So thinking about recommendations for policy and practice, and really this is my transition to really wanting to open it up to the wealth of experience that we have here on the call. But I'll throw some things out there, and then I really want to hear from others. So, the VA holds significant leverage to improve the quality of CNH-based hospice care through contracting processes. And one piece that we brought out through our findings was considering including BFS scores in CNH-based hospice care contracting policies. There's CLC, CNHs and hospice agencies are being chosen for the VA to contract with them, and bringing in this information about BFS scores, I think, could be really important. The VA's efforts to improve CNH-based hospice care should include particular focus on those domains where we saw some of the biggest gaps: PTSD management, emotional support, and guidance about VA survival and funeral benefits. Big plug here for the We Honor Veterans program and the role of expanding it potentially into VA contracted community nursing homes. So I know some of you even are, going back to the poll, are directly aligned with the We Honor Veterans program, but some of you may not be familiar with it at all. So, this is a voluntary program that's a joint effort between the VA and the National Hospice and Palliative Care Unit. And focuses on providing a high quality end of life experience for veterans outside of VA settings. So the We Honor Veterans program, and I definitely want Catherine to jump in during the question and answer, because she'll be able to give a lot more. My number that I had was that the We Honor Veterans program currently partners with over 4,400 community hospice agencies across the country. And partnering agencies can achieve one of 5 levels of participation, which indicates their capacity to meet the unique end of life care needs of veterans. But Catherine, put a pin in that one, because I'm sure that you can expand on that. And then the last thing I had listed as a bullet point, I alluded to before, which that consider mobilizing VA to intervene in here, the VA has a community nursing home oversight. So VA CNH oversight. And this is a group of nurses and social workers. So who better trained? I love that we're like 3/4 of the audience is nurses and social workers, to provide more concrete support and assistance to hospice patients. So part of the, not to say that they aren't already incredibly busy, but myself and others, Carrie Levy out of the Denver VA, some work that she has done has really ended with this idea of, wow, like we have these really high, like very skilled nurses, social workers, who better to try to provide some more support and assistance to these patients in community nursing homes. All right, so I will end there. These were the learning objectives. I actually put them at the end as kind of a test of myself to say, okay, learner will appreciate the nursing home setting is a critical venue for death in the US. You'll understand how family reported quality of end of life care is much better when veterans receive hospice in VA nursing homes compared to community nursing homes. Appreciate some potential contributors to these quality disparities. And then this one is what I really wanted to leave the last 20 minutes about, which is learner will be able to brainstorm ways we can improve hospice care and community nursing homes nationally. And I only gave you, a tiny bit of my thoughts. I really want to open it up to the group for next slide questions. But also definitely comments.
Oh, goodness. Thank you, Melissa. I know it's a lot to digest. I see the questions are coming into the chat box. Please continue to send them. Let's see. Let's get started with I have seen many results over the years for BFS feedback on CLC and acute care deaths, but never for CNH deaths. Are these separately reported?
Okay. And I'm a visual learner, so I love that they're in there too. So I've seen many results over the years for BFS feedback on CLC and acute care deaths, but never for CNH deaths. Are these separately reported? So yes, and this I think was, so this absolutely, that's what happened starting in fiscal year 2020 was that those who are placed in CNHs for the purpose of hospice care, they receive the bereaved family survey. So it isn't all CNH deaths, is my understanding. Scott, definitely fact check me on that. But at this phase, but it's all veterans who die, who've been placed in these community nursing homes for the purpose of hospice and end of life care.
Yeah, a lot of comments about all of the tremendous data. Oh, great question. Any effort to compare the Medicare star ratings for CNHs and CLCs? Current ratings of CNH locations are down significantly. Not sure if this is the case for CLCs.
All right, so I'm going to take my shot at this. We do have CLC compare. Oh, I may have to pass this one on to Scott. But the Medicare. So my understanding is that the CLC compare matches with the Medicare star rating measures. And sorry, for CNHs and CLCs, right? So that part of well, so a couple thoughts. One is the reason that we now have the bereaved family survey doing the 0 to 10 scale is because the hospice CAPS, if I'm getting this correct, uses a 0 to 10 scale. So that was with an effort to be able to align with CAPS, I believe. Now, one of the key pieces for the Medicare star ratings and also CLC, the ratings that are happening in nursing homes, there's really not the pieces that go into that, not much focused on end of life care, like really very, very little, and really very, very little that's even patient and family reported data. So it's I'm not going to be able to list them all off, but I think some data that has not been formally reported yet, more to come from the Veterans Experience Center, kind of about that exact question. I don't want to overstep with regard to findings, but it's critical. It's a great question, Sarah, definitely. Do you want to jump in, Scott? I feel like that was like about as clear as mud.
Oh, no, that's fine. I think you're right on target. It is we wanted to be able to better compare to the Medicare hospice cap survey. So we use the identical overall rating question. So yeah, you're right on target. And the only other, I put it in the chat, is just to say that the bereaved family survey findings from bereaved family members in veterans who died in contract nursing homes, that information is not reported widely. That is merely kind of on a pilot basis, and the information you shared and used in your publication and research is not widely shared.
We also thank you, Don Gilbert, for adding all CNH hospice deaths that are contracted with VA. Data is currently not reported out to the field. So I did also want to add, just given I know the majority of our attendees are from within the VA, but did want to just ask any of the community hospice folks that may be on, just something to noodle on. You're welcome to send it in the chat or in the Q&A, but you know, just sort of thinking, given that nursing homes are such an important venue for care at the end of life, thinking about hospice cap scores, excuse me. So why won't Medicare make the hospice cap survey results available for patients getting hospice in a nursing home? A couple other questions just to noodle on. And again, you're welcome to raise your hand or enter it in the chat box. Are there any barriers that you've experienced in that collaborative relationship among community nursing home staff with your hospice agency staff? Or what are some key examples of how to build rapport with nursing home staff or nursing home leadership? Let's see, and I am now getting...
Pull a question from Daisy. She's kind of wondering why patients' length of stay is so much longer in the community nursing homes, and what the implications of that are, if it potentially means that patients are not being as well screened for hospice. I don't know if you can speak to that at all, Melissa.
Yeah, it's a good question. And you know, quite honestly, the way it's funny how you write these, you know, you do these analyses and you write these papers. And I remember many, many moons ago, we noodled on that a lot in terms of why we thought that was. And the speed of research, that was a long time ago. And so I'm on the spot, not having thought about it for a while. And so again, Scott, feel free to jump in, but I am.
Oh, I don't have anything to add there. How do I want to say this? I think it's worthy of explanation, but I have not seen and don't know of a specific answer where I've seen kind of evidence to support it. I think it's a very interesting question.
Mm-hmm. Mm-hmm. Yeah.
We have a comment. I'm a geriatric hospice NP and work in the CLC and admit hospice patients also to the CNH. I feel it would be extremely beneficial to our veterans to have a team to look at the medication regimens, especially pain control, meet with the families, discuss benefits available. I think the families would really appreciate this and the veterans would benefit in so many ways. I feel we lose them once they're admitted into the CNH, and the data reflects this.
Mm-hmm. Mm-hmm.
We have another comment about staff turnover, and using agency staff makes it much more difficult. Outside of service connection rating, can veterans be eligible for hospice care within a CLC if home is not appropriate for the patient?
Say that one more time. Outside of service. Okay,
Outside of
there's my
connection rating, can veterans be eligible for hospice care within a CLC if home is not appropriate for the patient?
So what catches me about this, just as a point of clarification, and I'm just going to put it in there that Scott, you just interrupt me and fact check me anytime, and I won't say it each time. But one important piece here is that service connection, if is not a requirement, so to be qualified for long-term care within the VA, there's definitely that service connection, but all veterans who are enrolled in the VA, regardless of service connection, are eligible for the hospice benefit.
You nailed it, Melissa. This is Scott, and just to add it, take it even a step further, that there may be some non-enrolled veterans who were not eligible for VA care because of high income, and the VA defines that high income. I don't know the exact figure, but I think it's in the range of $50,000 or something. And if you become hospice eligible, that can get you in to be enrolled in the VA under the catastrophically disabled mechanism. And so even veterans who the VA may have said, sorry, you can't enroll because of your income being so high, you're a non-service connected veteran and all of that. When you're a veteran and you're needing hospice care, we have what I call a portal to get you in, and you jump up to a category 4 there, a priority 4. And so that's good. And then just one other comment I'm back on the geriatric hospice nurse practitioner talking about, it sounded to me in that chat comment about really VA staff taking more of an ownership role in the care of veterans in contract nursing homes. And I just wanted to let you know that my understanding is those contracts are written in such a way that the contract nursing home is obligated to provide that primary care. We do have some oversight responsibility, but I've not seen that to the degree of what I will call micromanaging what medications are prescribed and such. So I think there's a contractual issue there that kind of delineates who has ownership of the care plan, the primary care plan.
I'm going to keep going through. Sorry, Melissa, I didn't mean to cut you off.
No, not at all. No.
I'm going to keep going through the comments and questions. They're filing in. Our CLC is very specific on admission, and if it's a hospice patient, they have to be near end of life for admission. Otherwise, they send out to CNH if the patient is estimated to make it more than a few weeks.
So that could explain some of the difference in hospice.
Yeah, good. Yeah. And I just share, this is from someone who works in a 17-bed hospice in a VA community living center. You only have so many beds. And if you have long stay patients, which is possible, you just don't have the bed capacity in many of our CLCs. And thankfully, we have what I refer to as the safety net of VA paying for the room and board of the contract nursing home and offering to pay for the hospice care as well. So it's not perfect, but we're trying to fill that need. I think the Department of Veterans Affairs is trying to fill that need as best they can.
Let's see. Yeah, many CLC inpatient hospice units have stricter criteria than broader hospice criteria. For example, many VA inpatient hospices screen and admit those who are very close to end of life as opposed to meeting the broader hospice criteria. Our CLC.
And I would just add to that, because I also, so within the GIP Medicare benefit, I feel like it's really narrow, like to get somebody general inpatient hospice, sort of outside of the VA under Medicare, a symptom that cannot be controlled in any other setting, very narrow. So I actually feel that the VA it's like the in between. It's that compared to GIP, the criteria to get into the CLCs for hospice and palliative care, I find to be a much more generous benefit than I feel that the Medicare benefit really, with this idea of an uncontrolled symptom in any other can't be managed in any other setting, misses a major reason that patients cannot receive hospice at home. Yes, sometimes it's a symptom, but so much more often it's the caregiver burden, the 90-pound wife of the, 130-pound husband who's delirious trying to climb out of bed, has to be turned every time, is incontinent. And I feel like the VA does a much better job realizing the need for inpatient hospice in that setting than Medicare does.
Let's see, we have another comment. Sometimes patients who were in home hospice then come to CNH placement, have more help, more assistance with eating, obtaining food, fluid, and then they thrive for a short time, extending their lives due to the CNH placement with care, especially if the veteran lived alone at home, excuse me. Let's see, a couple of thank yous for all the clarification. Let's see, we have a question. What is the explanation behind the equal rating in patient in hospice unit versus hospice care in CLC?
So I would definitely let Scott speak to this, but I think that it is an indication that it's just really permeated the CLCs. I think that that the sort of, I think it did start more with the hospice and palliative care units perhaps, but I think it's a sign that the culture that exists and the training really has, I don't want to say trickled down because it's not up and down, but has really, spread through the CLC's ability to provide good end-of-life care.
I agree, Melissa. I think there's been, I'll call it a little bit of a spillover effect of that culture. And that's the best explanation I have for that.
Let's see, we have a comment. It is frustrating that some VAs do not have CLCs, such as us in Indianapolis. And we have found that the closest CLCs are often not accepting admissions due to COVID or prioritizing veterans from their own service area first. Let's see. I think it is difficult to compare apples to apples for CLC hospice to hospice care at VA. The CLC staff or VA employees and CNH staff are not, even if there is a contract in place. So process changes are easier to implement at CLC versus a CNH. Certain things on the survey, such as educating families about burial benefits, can be equally compared, but kindness of staff would be trickier since we only have so much control in a CNH. Let's see, another comment. Our CLC inpatient hospice only recently started accepting veterans with up to a 6-month prognosis. Previously, only veterans with an approximately 2-week prognosis were admitted to CLC inpatient hospice. Veterans with a longer prognosis were provided with CNH EOL contracts. Their comment about state veterans homes, as they are a good option as well to consider. A couple of folks chiming in and confirming that. Let's see. Are state veterans homes used for hospice beds like the CNH homes?
Scott, I know we've talked about this before, and I don't remember.
I don't think I know the answer to that right now. There used to be some state veterans homes who actually contracted with community hospices to have some designated inpatient beds in the state veterans home. But boy, COVID threw that all into disarray, and I don't know.
Okay, comment. I think in the CLC, we work with only veterans, and in community homes, there is a mix, and veterans have unique systems, which can be more challenging. CNH homes are not used used to or trained as well with this population. This is a wonderful presentation and so appreciate this discussion. I was curious to know further your thoughts about support of CNHs for this care. Do you think transitional care models for short-term involvement during transitions or continued support throughout the episode of care would be more impactful and cost-effective?
That's a great question. And boy, do I wish, Marcus, that you could speak because I know that you would have a much, do they have the ability to unmute?
If you raise your hand, I can allow you to talk.
Marcus, you're like, wait a second, I asked the question, but I would love, I know I would love to learn more about transitional care models than I could offer. And I imagine others in the group could learn as well, not to put you on the spot. I know Marcus, so I know that he's a can talk off the top kind of guy.
Dr. Wachterman, I so appreciate this conversation, and I think your data is so important and so impactful. And one of the things that we've been exploring through the Geriatric Extended Care Service is how best to support our CNH community nursing homes. And one thought is, could we have short, high-touch involvement during the transitions in care, and then kind of peel back that involvement as the CNH gets used to the veterans and understands their needs, and whether a similar type of model might be effective for end of life instead of throughout the episode of care. And I just was curious your thoughts about that, and if you thought that might work in this population.
Yeah, I think it's a great idea. I think that, as a palliative care, doctor in hospice, certainly from like the symptom management and sort of emotional sort of support, getting an upfront sort of alliance transition plan of care in place, I think could definitely add a lot of value. I think some of the pieces that we measure around sort of the moment to moment, day to day, feel that their care needs sort of most, I don't have them, you would think I would have them all memorized, but, care and kindness, kept clean and whatnot. I don't know, just off the top of my head, I don't know if those would necessarily be as easy to impact with the sort of intervention that you talk about, but I think that a lot definitely could be.
Okay, I know we're right at the top of the hour and a lot of people will have to jump, but I also want to be very mindful of Melissa's time. If you do have a couple more minutes to stay on.
I absolutely do, but I will not be at all offended as I see the 246. Wow, thank you guys. Just plummet right off, so no.
Others still coming in. Yes, I'm going to keep going through the questions in the chat. However, there are a few other people that have their hands up. So I am Carlos Rodriguez. Let's see. You should be able to speak right now. Do you have a question? I'm going to try one more. We had Rochelle Flamio. And if there's anyone else who would like to speak, again, just please raise your hand. So Karos and Rochelle, you do have the ability to chat right now if you can unmute yourself. But otherwise, let's see. I already, since the last time I checked, there were 50 new messages. So I'm going to keep going through the chat box. Let's see, a lot of thank yous for a wonderful presentation. A big thank you so much. Your heart in this work is evident and inspiring. Great discussion. Thanks so much for this excellent presentation. This was valuable information for me as a CNH coordinator. Very well organized and thoughtful, helpful data to review. let's see, this is again, Alessandra. We have a medical foster home program and community residential care home program as well, which assists with cheaper care rather than the nursing homes. I know not all VAs have these though. Let's see. How would a high touch model work? Are you exploring having providers go to the various CNHs or doing phone calls or warm handoffs? Just curious to know if this would be possible given that there are so many CNHs and catchment areas for the VA facilities.
Is Dr. Roop still on? This is
Like he is.
I could pause it, but this was really his baby. He may have needed to step out. Oh, there he is.
Ooh.
How have you been doing it in the work that you guys have been doing or proposing to do it?
Yeah, I think this is, I have to say, people are doing different models here. And I would say that, the model that we found, to be extremely effective is to have our clinicians go out to the contract nursing homes and establish connections. I will say that we have work to do here at VA Boston for this. But I do think that this is, I think establishing a relationship and having a contact within VA has been extremely successful. And I think it's really been a benefit for everyone.
Thanks, Dr. Roop.
Dr. Roop, I hope to see this model explode within the VA in years to come. Okay. Again, we have a couple more minutes if there are any remaining questions. Feel free to enter them in the chat box. Awesome presentation. Thank you. Oh, interesting question. How will, if any, the PACT Act impact today's materials?
Okay, I definitely have to turf this one.
Oh, I mean, the PACT Act is, a promise to address toxins and toxics. And I think that is something I would recommend Googling the VA PACT Act and resources. I think the bottom line is that all of us, especially those in hospice and palliative care, should make sure that veterans that have been impacted by these toxins are getting whatever VA benefits they're entitled to. And I strongly recommend reading and getting to know those diagnoses and what we can do, we, Department of Veterans Affairs, can do to help these veterans and their families and perhaps surviving families with ongoing support. So.
I was just going to highlight what Mary Ersick, whoops, it just popped, had written in the chat, which is, I think there are many opportunities for collaboration between palliative care and the VA CNH oversight program. So I'm wondering if, what Dr. Roop is talking about, and keeping in mind that we have this VA CNH oversight program, that, maybe some sort of passing of the baton, this high touch piece, and then really looping in, the CNH nurses, social workers that are involved, as somewhat of a continuity. It's probably a little pie in the sky. I mean, people only have so much, but at least that you're doing this high impact piece, some degree of awareness within the CNH oversight staff.
Thank you for the wonderful presentation. Sorry, I think I just interrupted you, Marcus. Okay, if there are no further questions, oh, wait, one more. Will Mission Act apply to community care in terms of long-term care?
Boy, this is Scott. The Mission Act was a very significant change in legislation to allow veterans to get care in their community. It really opened the door for, rural veterans or veterans more than 30 minutes from a VA medical center to get the care in their community, and for those veterans that just for whatever reason may not have wanted to use the VA could get care in the community. I've not seen the Mission Act impact long-term care eligibility in geriatrics and extended care. We've always had contract nursing home programs. I don't think it greatly expanded or changed that element of VA delivered or purchased care.
Scott. I am not, a comment. A great VA model for this would be the behavioral recovery outreach teams being implemented between CLC and CNHs currently. Okay, I'm not.
Yeah. Dr. Sheed, would you want to come off and tell us?
I've never heard of the behavioral recovery outreach. I'm sorry, I just don't know what that is.
Veronica, would you like to raise your hand and we can unmute you?
Hello, can you hear me?
Yeah.
Yes.
Okay. Hi. The behavioral recovery outreach teams are actually being implemented. I believe it's Vision 23, not exactly sure. But those teams actually came out of a need from dealing with older veterans who had dementia-related behaviors. So they started a program in which, while the veterans were actually on CLC, they would implement the STAR VA program and other behavioral management programs while they were there. And then what they were noting is that a lot of the work that they had done would go by the wayside when the veteran was transitioned to a community nursing home. And so because of this, they started a program where their team actually works to use that plan that has been implemented on their CLC or has been managed there and moved to and use that and utilize it and integrate it into the care and within the community. So they actually have people who are managing that. So it is definitely a transitional care model where it is the purpose of that is to move veterans from receiving care in CLC to receiving it in the community.
Thank you for sharing this.
Hey, last call for questions. We're wrapping up, but I did want to just echo something Dr. Wachterman said earlier. Yes, we do currently have over 4,400 community We Honor Veterans partners now. So if this is something that you are not familiar with, please hop onto our website. I'll enter the link in the chat box again momentarily. Again, this has been a longstanding partnership between the National Hospice and Palliative Care Organization and the Department of Veterans Affairs, primarily Dr. Scott Shreve, who is just pioneering so much work, and we are grateful to work with him and continuing through in the community nursing home sphere. But everything that is on the We Honor Veterans website is free and open, available to everyone. All of these incredible webinars that we have are posted there on our resources page, including the slides and any other links that may be helpful or related to this content. So Another friendly reminder, also keep an eye on our events calendar. We have a lot of community partner activities coming up, particularly with Veterans Day just around the corner. Have also a lot of LNEC trainings coming up. And then other community-wide like hospice veteran partnership events throughout the remainder of the year as well. And if you have any that are open for other folks to attend, please send them our way and we'll be happy to post those for you on our website as well. So again, the recording will be posted. Thank you again so much to Dr. Wachterman and of course, Dr. Shreve and Ryan Weller, our dear colleagues. For this presentation, we're looking forward to kicking off this initiative and doing everything that we can to improve the quality of care for veterans in these community nursing homes. So definitely more to come. I feel like we have just opened the floodgates for questions and conversations, which is something that we are definitely wanting. If anything else pops into your mind or you have some follow-up questions or you're wanting a little bit of information, reach out to us, the We Honor Veterans team. I'll put our email in the chat box as well. It's just veterans@nhpco.org though. We're here. And then I know that Dr. Wachterman did share her email at the end of the slides as well. So you're welcome to reach out to either of us. I see a final Go Army Beat Navy. Thank you so much again to everyone and have a wonderful day.
Thank you.
Thank you.